Okay, I'm going to Okay. Welcome everyone to this discussion of FDMAS and reproductive health with Dr. Veronica Gomez-Lobo and FDMAS Alliance President Lauren Ruotolo. This is the 6th and final installment in our 2021 webinar series. I'm Tova Burstein, Community Engagement Director with the Alliance, and as usual, I'm going to start us off with some quick housekeeping. We're recording today's session and we'll share it afterwards for anyone to access and share freely. We have collected questions ahead of time via our registration form, but we'll also watch for questions on the Facebook chat. And you can test that feature by sharing where you're watching from in the chat now, if you'd like. Awesome. Welcome, everybody. At the closeout today, we'd really appreciate it if you'd complete our 3-minute post-webinar survey, which will help us show our impact and continue to support programs like this one. And finally, this program is made possible by our donors, with special thanks to Ionis, Ultragenics, and to our Charlie's Angels monthly giving circle for their support of our educational programs. We're really committed to keeping this material free, and you can help by making a donation on our website today. Without further ado, I'm going to introduce our president, Ms. Lauren Ruotolo. I'm honored to have here today. Lauren is Director of Creative Partnerships at Johnson & Johnson's Global Content Labs. In addition to being FDMAS Alliance's president and an ardent community advocate, she's also a writer, designer, and content creator, among many, many other hats she wears. Lauren, thank you so much for being here and for sharing your story.
Hi, everybody. Tova, thank you. And Dr. Gomez-Lobo, such a pleasure to be here with you again. It's been a few years, so I look forward to our conversation today. Again, thank you, Tova. As Tova said, I'm Lauren Ruotolo. I'm the president of the FDMAS Alliance and also a MAS patient, McCune-albright syndrome patient, diagnosed at 18 months old. But the first sign that I had McCune-albright syndrome was actually at 9 months old when I had precocious puberty. And from that point on, my life and the trajectory for my life was changed forever. At that point, I had my period, got it for almost 3 months before any doctor believed my parents and believed that I was actually bleeding, because they had never seen a toddler at that age really get their period. And so later on, they were finally able, through Depo-Provera shots every week that I had to get to stop that, and through a few other medicines. But the medicine that I remember most was getting injections every week. I got those through the age of 8 years old. And then at the age of 18 months, I broke my first femur bone just walking with my father, and I fell in a pet store. And from that point on, I broke my femur and hip bones at least 10 times before I was 11 years old. Also, at the point when they took me off of all the medicines for my precocious puberty, they put me on a new medicine, and at the age of 8.5, 9 years old, I directly went into menopause. And so one could imagine, from a parent perspective, from a child perspective, and from a doctor perspective, that again was the unknown. And again, like, my life changed during that moment in time. And it was about 6 months that I went through that, and they really couldn't figure it out. So they took me off of the medicine and said, she will get her period probably right away. Well, once again, we went into the unknown, and that was wrong. And I got my period at the age of 13 and then got it off and on for years to come until I was on contraceptives, which I now at the age of 45, I'm still on. The FD MAS is still obviously with me and has been changing throughout my decades of my life. Most recently, last week was just inpatient at the National Institute of Health, where most of you know that they do a natural history study, which is where Dr. Gomez-Lobo is currently. I'm also, as Tova said, an author of the book Unstoppable in Stilettos. I have a shoe line. I have working on a bunch of new projects now, and really a true advocate, not only for all of our FD MAS warriors, but for the disabled community as a whole. And what I am looking to do is to not only bring more awareness to the disabled community, but as a community that I call is an invisible community. And how do you turn the invisible into invincible? And so while there's a lot of work to do, I'm proud to say that we are, and hopefully will be getting there, and dedicating this next decade of my life to creating as much awareness and being an advocate for all those that either don't have, that either can't speak for themselves or don't want to speak for themselves. But the time is now to change the trajectory and to change the attitudes and the way that we see all people today. So I'm really happy to be here and really excited to have this conversation, because so much of having McCune-albright syndrome affects your hormones, and especially as a woman, it starts really early on in life. So thank you again.
Thank you, Lauren. Thank you so much for sharing. And this is such a personal, close to the heart conversation, and we're really grateful to have you here as an advocate and a leader to this community at all times. We're also very grateful to have the expertise of Dr. Veronica Gomez-Lobo. Dr. Gomez-Lobo is an obstetrician and gynecologist who specializes in pediatric and adolescent gynecology. She currently serves as associate editor of the Journal of Pediatric and Adolescent Gynecology, as well as chair of the Onco Fertility Pediatric Interest Network Research Subcommittee. She's the site primary investigator for the Disorders of Sex Development Translational Research Network at Children's National Medical Center, and serves as senior clinician and director of pediatric and adolescent gynecology program within the National Institute of Child and Health and Human Development. Her areas of focus include fertility preservation, differences in sex development, and congenital anomalies of the reproductive tract. So without further ado, Dr. Gomez-Lobo, welcome, and thank you so much for sharing your expertise.
Thank you so much for having me, Tova, and it's so nice to, thank you, Lauren, for sharing your experience. I'm kind of embarrassed about that introduction. So as a pediatric gynecologist, we take care of girls who have gynecologic problems. And so because of that, we actually do see a lot of girls with McCune-albright. But what I was going to share with you today was a little bit more of the, let's see, I'm sharing right now. Can you see that? So I was going to talk a little bit about women's health issues in general. And when we think about women's health issues, we think about puberty, which can happen early. We think about sexuality. We think about ovarian cysts, abnormal bleeding, fertility, preconception counseling, contraception, pregnancy, cancer screening, menopause, and a lot of other things. So these things all fall under women's health. And I'm going to specifically talk about the issues that are in red, because we've done a little bit of research in that, or thought a little bit of that, not because the others are not important. So I'm not going to talk too much about childhood and precocious puberty, but I'm happy to answer some questions about that later on. So the first part is ovarian cysts, and I think this is really important because people with McCune-albright can have the mutation of the Gnrh gene in the ovary. The ovary can kind of work by itself without having the brain tell the ovary to work, which is what normally happens during puberty. And when it starts working by itself, it doesn't do it in a coordinated fashion. So these cysts will grow and they can grow very big. And so cysts are very common in girls with McCune-albright, and we can see in girls with precocious puberty, there's a lot more cysts than in girls without precocious puberty, and that's because these cysts make estrogen. And the problem comes once women go past the puberty is that cysts are really common. So women get cysts anyways because the egg grows. When an egg is released, you get a second cyst where there can be bleeding inside. And so it's really hard to know when women have cysts. Is this because of the McCune-albright or just normally what happens in women sometimes when they ovulate and they get these cysts after ovulation? And
Dr. Lobo, question for you with regard to ovarian cysts, because this is, as you said, it's very common and it's something that I myself have. And when I was a teenager, as soon as I went through puberty, they did say that the amount of cysts that I was having, while they did resolve, it delayed my period. And so I wouldn't get my period on a monthly basis.
Right. So that's a really good point. So down here, I have the menstrual cycle, which is very complicated, but essentially the cysts that get activated because of the McCune-albright, the cyst starts to grow. That makes estrogen. But the way women have ovulation is through the brain stimulating ovulation. And if these cysts are growing independently, what will happen is the cyst will grow, but there's no ovulation. And when there's no ovulation, then the period will be delayed. And that's why you can have the irregular periods. And that's why you can have heavier periods, which I'll talk a little bit about, but that's a really great question. And so it's hard to know what to do, but both the cysts that people with McCune-albright get because of the Gnrh gene and the cysts that people get just because of ovulation and menstruate and just what happens in the menstrual cycle, both of those kinds of cysts should go away. But sometimes they can cause pain, especially if they break, and sometimes they can cause the ovary to twist. And the most important thing is that in young women, if surgery is needed, it's really important to just remove the cyst because we don't want to remove an entire ovary because that can affect fertility. And I'm going to address that a little bit more in the next slide, but this is how you can do a laparoscopy. And a cyst is really like a sac of fluid. And the ovary, the normal ovary is sort of stretched over it, and you can kind of peel it almost like an orange and take it out. If it ovary's twisted, then you can just untwist it, and it has more than a 90% chance of working, even if it was twisted for a long time and it looked like the ovary was affected. So the most important thing is that girls and women with MAS be evaluated by experts in the field. So people who understand this, because what happens is when they look at these cysts, somebody may think it's something else. And so it's really important that somebody think about McCune-albright in a child who has a cyst before they decide that it's a tumor or something else. And then I did want to say that in case because the Gnrh gene can be in different parts of the body and it's not everywhere, you could have one ovary that has it and one ovary that doesn't have it. And so there have been cases where it's only in one ovary and that ovary is causing a lot of trouble and the ovary's been removed and it's decreased the trouble. But we do not want to remove an ovary in a young person without really having thought it through, because removing that ovary, if the other ovary has the Gnrh gene, is not going to help. It's only if only one ovary is affected. So that's why it's really important to talk to somebody who's really thought about this and very, very carefully and thought about the implications.
So I have a question for you with regard to the ovarian cyst. As you said that, they can, a doctor that may not know that you have MAS may think that it is something else. Is there a way that us as patients or as, other doctors can really see this on a scan and say, we're identifying this as a different kind of cyst than the normal cyst that somebody else may get, or that it's not a tumor, or that it's not? Because I myself had been through that when I went to, a pediatric gynecologist, and at first they said, oh, we think that, you could have a tumor. And so I know what that feeling was like, but then my endocrinologist had to get involved and say, no, this is not.
So I would hope that most pediatric gynecologists would know what McCune-albright is and understand how it works and the pathophysiology. I have found this to be the biggest problem in people who don't have the diagnosis of McCune-albright. So they come in with pain or some sort of symptom or even bleeding, and then they do an ultrasound and they see this very large cystic ovary. And is this a tumor? And I've even had endocrinologists say to me, this child has a tumor, you need to take the ovary out. And then we sort of evaluate it. There aren't a lot of things you can do on the ultrasound. So cysts usually have fluid inside of them. This is a granulosa cell tumor, which is a solid tumor that makes estrogen, and that does need to be removed. And that's not what McCune-albright patients get. So I think it's really important to distinguish the two. You can do blood tests called tumor markers, but I think the most important thing is that you have a thoughtful doctor. So if you know you have McCune-albright and somebody sees this very large ovary with cysts and they send you to a gynecologist and the gynecologist is worried about a tumor, I think it's important to say, but I have McCune-albright, and McCune-albright, we get these cysts. And then that gets the ball rolling of somebody thinking about what it could be. Does that answer that question?
Yes, absolutely. But, as we know, McCune-albright is so rare. And, from experience, a doctor may have heard of it, and I have been told that they sometimes call it a board disease because they have to know it for their boards, but then they never see it again. And
I actually was asked about it in my boards before I had ever seen anybody with McCune-albright, before I did pediatric gynecology. This is something I think a lot about because I see a lot of rare diseases, and the families end up teaching me a lot about those diseases. And if you have a thoughtful doctor, they don't need to know a lot about this. They just need to be willing to read and to think logically. And so if you go and read and you see, okay, McCune-albright, it's associated with a Gnrh mutation that can be in the ovaries, that can cause spontaneous ovarian activation, then somebody like that can really thoughtfully think through it. And I think the biggest thing, if you're looking for a doctor who may not have experience with McCune-albright, which is going to happen, then the biggest thing is to find a doctor who's willing to think things through and who's open to learning and researching things.
Right. Thank you.
Along with this comes this issue of menstrual dysfunction. And this is the research study we did with the MAS researchers here at the NIH, where one of my former fellows called adult women who had McCune-albright to ask them about their period, their obstetrics history, their gynecologic history. And she was able to get some very detailed interviews with 38 women with McCune-albright. And again, that just shows how rare it is, right? This is years and years and years of patients at the NIH, and this is how many women. So there's very little research on this area. So this is about as good as we get. About 35 of these, or 92% of these women, had a history of precocious puberty. And 86% of them had either irregular periods or periods that were very long. So greater than 7 days is considered too long. Periods that are less than 24 days or more than 38 days were considered abnormal, or they have abnormally heavy periods. So like you said, Lauren, if your period is delayed because of these cysts and you don't ovulate, what happens is the lining of the uterus gets very thick, and then that causes very heavy bleeding when it does happen. And 34% actually had anemia because of the periods were very heavy. And 3% of the patients actually had such severe bleeding, they had to have blood transfusions. So this is an important issue for women with McCune-albright syndrome if they have ovarian affected McCune-albright syndrome. And so the most common treatment for these women was birth control pills, which should help with the bleeding. It's not going to help with the cysts, but it will help with the bleeding. And it was effective for 72% of the women. But what really concerned me is 9 women underwent hysterectomies because of the bleeding. And 7 were performed less than 35 years of age. So that was like a really big deal. So why can people have heavy bleeding? So one could be if there's fibroids or polyps, which is not something that we think of specifically for people with McCune-albright. You can have anovulation, which is exactly what we were talking about, Lauren, where an egg doesn't come out and so you get buildup of the lining of the uterus. So that's important. You can have endometrial hyperplasia or cancer. That happens later in life. Endometrial hyperplasia happens in people who have what we call unopposed estrogen usually. And that's when there's estrogen, but there's no ovulation. And so you don't get the progesterone to protect the lining of the uterus. But that only happens after years and years and years of anovulation, and birth control pills protect against that. And then some people have very heavy periods because they have a clotting disorder. They just can't clot. And that's not an issue usually for women with McCune-albright. I'm thinking of these 2 issues in the middle. So when we think about treatment, we have certain treatments that we give for bleeding control, and it can be birth control pills or ring or patch that have estrogen and progesterone. We can give progesterone only, which can be the shot or the implant or the progesterone IUD. All of these will help with the bleeding in anovulation, and it will help with controlling, preventing cancer of the lining of the uterus. Gnrh agonist is something we use to stop bleeding in some patients. It may not work in people with McCune-albright because the whole point is the ovaries activating on its own. The Gnrh agonists are working at the level of the brain to stop the brain from pushing the ovaries into working. And so that will not help with somebody with McCune-albright. And I did want to mention that there's these new surgeries that we can do where we're not doing a hysterectomy, where we're just burning the inside of the uterus, that are like in and out surgeries without any cutting that people can recover very quickly. So those are options for somebody who's done with having children. So I wanted to talk a little bit about what we found in the fertility. So there were 38 patients that we talked to, 17 tried to become pregnant and 14 became pregnant. A lot of them took a little more than a year to get pregnant, but they did get pregnant. They didn't see an infertility doctor. So it may be that because there's not an egg coming out every month, it just takes a little longer. But I wanted to concentrate for this slide on 8 women had unintended pregnancies. They did not plan to get pregnant. So I did want to talk a little bit about birth control. So birth control options now, we have barriers, spermicide, combined oral hormonal contraception. Those are the ones that have estrogen and progesterone, which I mentioned before. Progesterone only contraception, intrauterine devices, and sterilization. That's what we have available right now. And estrogen and progesterone contraception, we have the patch, the ring. There's a ring now that you can keep in for a whole year, and the birth control pills, and they have a bunch of benefits. So there's less bleeding and anemia. There's less painful periods. There's less acne or facial hair. There's less ovarian and cancer of the lining of the uterus. And there's less ovarian cysts, but that probably won't help women with McCune-albright. But it will, these other benefits still apply. The problem is blood clots. So birth control pills with estrogen or any birth control with estrogen will increase your risk of blood clots, which is not, and high blood pressure. Both of these are not necessarily increased in women with MAS. So birth control pills are a good option. Progesterone may be an even better option because the McCune-albright is causing this spontaneous cysts to form. but they may not be ovulating. Adding the progesterone is what the body would have made if they were ovulating. And so it's going to protect the lining of the uterus. We have the Depo-Provera shot. We have birth control pills that have only progesterone, the implant, and then the IUD that has progesterone. And as I said, it may be ideal because the ovaries develop the cysts that produce estrogen, and birth control pills have estrogen. So do we want to avoid doubling that estrogen? We don't know. There's no answer to that, but progesterone only may be ideal. And then the other concept I want to discuss is that long-acting reversible contraception are the best methods of birth control. So the lowest chance of getting pregnant without wanting to be pregnant is with these, and those are the IUDs and the implant. I did want to mention emergency contraception because it's available over the counter in the Plan B. And so that's really important for everybody to be aware of. If you have unprotected intercourse and you take Plan B within 72 hours, it has a very high protection from pregnancy. And then there's Ella, which is an anti-progesterone, which also, but this one requires a prescription, but this one is you can use up to 5 days later. And a copper IUD is something else that can be used as morning after. Unfortunately, the copper IUD is associated with heavier periods, so it may not be the best thing for somebody with McCune-albright. And again, how different birth control methods work better than others to prevent pregnancy. So the long-acting reversible contraception, like the IUDs and the implant, 1 in 100 women will get pregnant in a year, versus birth control pills, patch, and ring, it's like 8 in 100. This is too small for me to see. And then condoms, it's a lot more. So this is an important concept. And then I just wanted to run through this really quickly because people can have other medical issues. The CDC writes this every few years where they give recommendations for what birth control is safe in different medical conditions. Now, they don't include McCune-albright, but if you have other medical issues, your doctor can refer to this to see what's safer and what's less safe for you.
And Dr. Lobo, a lot of us are on birth control so we actually get our period, you know, like myself. What had been most recently recommended is that I stay on the birth control and don't use that week to menstruate and just stay. Can you tell us?
Yeah, that's a really great question. So all the things that have estrogen and progesterone, and it started out in the 1960s with birth control pills. And the guy who created birth control pills created this pill-free week because it was very interesting. He was Catholic and he thought the Pope would accept this method of birth control if women were getting periods. But you don't really need to have a period. And so the patch is done so that you use it 3 weeks and then 1 week off. The ring you take out after 3 weeks, but all of these you can continue to use and avoid a period. The only problem is if you're using it in the continuous fashion, which is what you're talking about, which is to skip the placebos or keep going with the patch or keep going with the ring. So many women can't go for a long time without bleeding. So some women will go, 6 weeks and then they'll start bleeding, or some women can go a year and never bleed. If you do start bleeding, you do need to stop the method for 4 days, because otherwise the bleeding will last for a very long time. So you stop the method for 4 days, allow a period to happen, that sort of cleans everything out inside, and then you can keep going.
And is that called breakthrough bleeding? Or
yes, that's breakthrough bleeding. What a great question. And then the other issue is that I get asked by a lot of patients is, well, if my period isn't coming, isn't that dangerous? Well, if you don't get a period and you're not using any medications, then we need to find out why you're not getting a period, because that can be because of a medical issue. But if you're taking birth control pills or a patch or the ring all the time, then you're not getting the period because the lining of the uterus has gotten very thin. Same thing happens with the progesterone only. They actually most of them get rid of your period or make you have just breakthrough bleeding here and there. But these methods, we don't stop. We just keep using them. And if you're having a lot of bleeding with like an IUD, then we can add something else because the IUD has such little hormone that it's safe to add something else like a birth control pill or something on top of the IUD.
Thank
Great
you.
questions. So the next step I wanted to talk about was a little bit more about pregnancy, which I had mentioned before, because that's some of the questions we asked in this questionnaire. So we had 22 pregnancies, 4 had a miscarriage. Now that's normal. About 1 in 5 pregnancies in human beings ends in a miscarriage. So this number is normal. 6 people had an abortion because they did not want to be pregnant, and 1 had a fetal demise. Which it's very hard to interpret what that means. There were 13 deliveries from 9 women, 7 had vaginal deliveries and 6 had C-sections. So I get asked that a lot. Can you have a vaginal delivery? And it probably depends on whether the fibrous dysplasia affects your hips and your pelvic bones. So 4 of the C-sections were because of the fibrous dysplasia, and 2 is because of something going on with the baby, whether the baby was upside down or the baby's heartbeat or something like that. We did ask questions, and I didn't have the numbers, but I added the statement. We did ask questions about the fibrous dysplasia pain because many of you know Dr. Allison Boyce, and she was like, we really need to know, does the pain get worse during pregnancy or better? And it was pretty much equal. So some people got better, some people got worse, and some people had no change. So we didn't see a pattern in the pain, the fibrous dysplasia pain during pregnancy. The other thing that I've talked to Dr. Boyce about is we know that women with McCune-albright have had high estrogen levels. They've had high estrogen levels when they were children, and they've had high estrogen levels because of the cysts that develop. And does this increase the risk of precancer of the uterine lining? As I mentioned, when you don't ovulate, you have this increased risk. However, birth control pills and anything with progesterone will protect from that risk. Is there an increased risk of breast cancer? So we know estrogen has something to do with breast cancer. Is there an increased risk? And we don't know. We have question marks about these, but we don't know. And then could the Gnrh gene have an effect on breast cancer? We don't know. We did do a research study where we looked at the Gnrh genes in teenagers and young girls who had a type of tumor of the ovary that's benign. It's called a mucinous cystadenoma. And we had 5 girls, and 3 out of the 5 had abnormal Gnrh genes. And these were girls who did not have McCune-albright. So these were girls who we found this tumor in the ovary, and somebody thought, let's check for this gene. So, you know, could the gene be associated with other types of tumor formation? We do not know. So with that in mind, you know, what kind of cancer screening should women with McCune-albright be having? I think, you know, right now they're recommending to begin mammograms at age 40 or 50. There's some controversy there. Should it be earlier for women with McCune-albright? Probably not at this stage, but we again don't have large numbers of women to be able to say, but certainly at age 40 instead of 50, I would say. Cancer of the lining of the uterus usually presents with bleeding. So if there's abnormal bleeding in somebody with McCune-albright, I might consider doing an endometrial biopsy a little younger than what's recommended for the general population. Cervical cancer is what we check for with a pap smear, and the recommendations have been changing a lot. Right now, the American College of OBGYN says you should start having a pap smear at age 21, and then every 3 years. And after age 30, you can check for the HPV virus. And if the pap smear and the HPV are negative, you can go to every 5 years. I would say cervical cancer screening should be the same as the general population for somebody with McCune-albright. There's no reason why they would be increased risk that I'm aware of. And then colonoscopy, the recommendations have changed. It used to be that women should have it started at age 50, but now the recommendations are age 45 because the colon cancer is going up in the US in the general population. And we know that some people with McCune-albright develop polyps, so we don't know whether we should do this younger. So there's a lot of these I definitely would follow the recommendations, but these are sort of individual discussions you may have with your doctor about whether you're more concerned about some of these things. I didn't talk very much about menopause, Lauren, but I did want to mention it because, so the issue with what happens at menopause is the number of eggs in the ovaries have decreased so much that there's no more eggs to stimulate and to have ovulation and hormone production. So I would not expect that aspect to be different in women with McCune-albright. So once the eggs are exhausted, then there's no estrogen production and there shouldn't be the cyst formation that happens when women are younger and they still have eggs. Now, because women with McCune-albright can activate their ovaries independent of their brain stimulating them, does the menopause happen younger? We do not know. That we don't know, but I did want to mention that. And then there's this whole, I could talk for an hour about estrogen replacement therapy and the risks and benefits of it. But certainly if you start early, it seems to be good for your bones and for your heart. So, those are big discussions to have with a gynecologist who's really thought about estrogen replacement therapy in general in women. And I'm not sure that it would be different for McCune-albright women, except that they were exposed to more estrogen maybe earlier.
And if you are, Dr. Gomez-Lobo, if you are taking some kind of contraception, is there then a certain age that you should try to come off of that?
Yeah.
Somebody like myself who has been on it for,
that is such a good
years.
question, Lauren. And, so we don't want people to get pregnant if they don't want to be pregnant. After age 40, it's hard to get pregnant, but it can happen. So we would definitely recommend contraception if you don't want to be pregnant and you are having intercourse and you have not gone through the menopause. However, the amount of estrogen that's in the type of estrogen that's in birth control pills is very different than what we give for estrogen replacement therapy. So as women start approaching age 50, average age of menopause in this country is 51. But as women start approaching, and also the risks of estrogen and blood clots increases with age. So the older we are, the more chances we have of having a blood clot. And so I actually think it's really reasonable once you start hitting age 40 to do like an intrauterine device with progesterone and then check to see if you're in the menopause. And if you are in the menopause, do estrogen in a very low dose. That's just a replacement to protect your bones and protect your heart.
Oh, wow.
I think that makes a lot of sense. There are low dose birth control pills, but there's still a higher dose than what we give usually for people in the menopause. And also when pills go through the liver, they increase your clotting factors. And so estrogen that's given through a patch, like we give after the menopause, is safer as far as blood clots are concerned. And again, people with McCune-albright are not, that I'm aware of, increased risk of blood clots, but all of us have an increased risk as we age. And estrogen increases our risk. So as we start piling risk upon risk, it makes sense to decrease the risk if you can.
Right. Thank you.
So my conclusions are that ovarian cysts happen even in adults. It's not just in kids, and this may cause increased estrogen. And in young women, if surgery is needed, every effort should be made to save the ovary. If the ovary twists, it should be detorsed and not removed. And on rare occasions, removal of an ovary is justified, but this decision needs to be made in a multidisciplinary team with expertise in McCune-albright. The second set of conclusions is that women with McCune-albright are able to conceive and carry pregnancies, but it may take them a little longer to get pregnant. And they can become pregnant without wanting to, and there's no contraindications to hormonal contraception, to birth control. The next one is that abnormal uterine bleeding is extremely common, and it results in significant morbidity, including severe anemia and hysterectomies. And most of our hormonal contraception can help to control this uterine bleeding, so we should not hesitate to use it. And then women with McCune-albright should be screened for cancer as recommended for the general population, with a caveat of a question mark: should we be doing slightly earlier screening for breast and colon cancer? And so with that, I'm going to end my show, and I'm happy to take any questions. I'm going to leave the slides just in case I need to refer to them.
Yeah, absolutely. Yeah. Thank
Lauren,
you both.
thank you so much for your questions, because they really help to hone in on some of these issues.
Oh, you're welcome. Thank you. It's always on my mind.
Yeah, this is a really valuable conversation. Thank you both. We have a lot of really great questions. Some of them you have addressed, and I think it's worthwhile just touching on again. I want to start with the first, which is sort of like due diligence. How do I select an OB/GYN? What are factors that I should keep in mind? It sounds like maybe it's worthwhile finding a pediatric OB/GYN. Is that?
So pediatric gynecologists, there's not that many of us. There's more. It's a growing field with fellowships. And so a lot of times pediatric gynecologists only see children. Some of us see adults. And so it depends on whether you'd find somebody who sees adults. I think definitely if you have a child or an adolescent, they should see a pediatric gynecologist if possible. There's also pediatricians who are adolescent specialists who can sometimes be helpful, but they do less complex care for the GYN piece. I think the biggest thing is interview your gynecologist. You're going to get a sense very quickly. Is this somebody who wants to work with you or somebody who doesn't want to work with you? If it's somebody who said, I never heard of McCune-albright, I can't see you, then that tells you something. If somebody says, I've never heard of it, but I remember reading about it in medical school, let me read up a little bit more, let me talk to a few people and let's see what we can come up with and plan for your care, then that's a doctor you can work with. And I think that's important.
I have just speaking to that point is, I myself, who am now 45, did not have a pediatric gynecologist. No one did recommend that to me. I just had my endocrinologist. Is that something that is, would you say it's newer today? And should, caregivers ask their endocrinologist, who is usually like one of your main doctors if you have McCune-albright's?
Yeah, that's a great question. So when I started doing pediatric gynecology in 2005. I had been a general gynecologist at that time. And then I started a fellowship in 2010, and it was the 4th fellowship in North America. So that gives you a sense.
Yeah.
Now there's 13 fellowships in North America. So and there's jobs everywhere. My fellows are having tons of job opportunities because most places are recognizing that it's a real needed field. So, when you were a child and adolescent, Lauren, there just weren't that many of us, but I think there's more and more over time. So I think it's worth asking.
Yeah.
And then for somebody who's planning to get pregnant, is there any due diligence that they should do? Testing with genetic partners, all that kind of stuff, but specific to FDMAS, beyond just recognizing that it could take a little bit longer?
So the general stuff, so you should be taking a prenatal vitamin with folic acid because it prevents neural tooth defects, and sort of pre-conception counseling, that would be for the general population. I think that other than that, the fact that it will take a little longer, or it might take a little longer. And I want to speak to that. So the fact that it may take a little longer should mean that you shouldn't get discouraged. But if you're older when you start trying, you don't have as much time to take a little longer, because all of us are born with a certain number of eggs and we lose them over time. So in general, we tell people that if they're 35 years old and they haven't gotten pregnant in a year, they should see a specialist. I think it's a very reasonable thing to apply that in this case also. It's want to delay the care. And then other than that, I think for preconception, there's nothing else that I am aware of or can think of. I think the biggest issue is going to be during pregnancy, assessing the fibrous dysplasia and its effects on the pelvis so that you can plan for the delivery or even the anesthesia. So you may need consults with anesthesia before you go into labor, if you planning around the delivery.
Absolutely. And actually, before we travel too much further down conception, there's lots of questions about contraception. And am I understanding correctly that all forms of contraception are available and there's no reason that anybody with MAS should not take one of these, but it might be a longer conversation with your care team about your specific goals and what else you have going on specifically with your endocrine system? Is that?
Absolutely. Absolutely. With a caveat that, you know, the best methods of birth control are the long-acting reversible contraception, which is, that applies to everyone. And then the second caveat is that things that have estrogen, like control pills or the patch or the vaginal ring, may increase the amount of estrogen in your body because your body may be making extra estrogen from those cysts that are activating. And we don't know what the effect of that is as far as risk of blood clots or long-term, but there's no reason you can't use it. It's just something to think about considering.
And then on the reverse side, you know, if somebody is going down the path towards IVF, are they able to go through that process? Are there special considerations they need to take?
So it's funny, we didn't ask any questions. All of our patients in that questionnaire got pregnant without undergoing IVF, but there's a reason, again, the ovary works on its own, but it also responds to the brain and to stimulation. And when you do IVF, you're essentially giving those brain hormones that makes your ovaries work in extra high doses. And so it may be, sometimes you try to shut the system down before you give those hormones, and it may be harder to shut the system down in somebody who has McCune-albright. But right now there's a lot of medications they can give to deal with that. So you can give letrozole to bring the estrogen down, and then you can give FSH to activate. So I don't think it should be that much different than somebody else who's going through IVF.
And what about, so if you are a teenager and your endocrinologist and or your gynecologist recommends some kind of birth control, so you do get your period because you do have a rise in cysts, how do you have that conversation with a parent or with a patient, because they are, a teenager and it could be construed in many different ways.
So that's interesting. There's a lot of laws all around the United States that we can provide birth control to teenagers without their parents knowing. So that's a whole nother issue, which is confidential services are protected by law. And so we actually kick the parents out of every room starting around age 13 for two reasons. One is because teenagers sometimes talk about things that they're not comfortable talking about in front of their parents. And it doesn't mean we're talking about sex. We may be talking about bullying or other things. And the second reason is that it's really important for the kids to start developing that relationship with their doctor and start transitioning that care. So that's a very important concept for us, and it's standard of care. But we talk about these, we provide hormonal contraception to kids all the time because they need it for medical issues. And so we just explain that birth control is medications and they're hormones that help protect the lining of the uterus or decrease bleeding or or one of those things.
Really excellent question, Lauren. Thank you so much for bringing that up. Then sort of returning back to the idea of conception and having a baby, there's lots of questions about whether FD lesions are more likely to grow during pregnancy. Human growth hormone, from the webinars we've had during this series, they've talked about how important it is to monitor growth hormone and how that affects all your other medical decisions with FD-MAS. What does that look like in pregnancy with FD lesions?
And I don't know the answer to that. Well, that when we did the study, we asked the women, did your fibrous dysplasia pain get worse, better, or did not change? And the answers were all over the map.
Yeah.
I'm not a pediatric endocrinologist. I don't know enough to say whether we should be following the growth hormone. It's certainly because, my feeling on rare diseases where we don't know things is to be cautious is better. So you may want to monitor things just so that we have an idea of what's happening, but I don't have a great answer for that.
Yeah. I mean, thank you so much for sharing that. We'll certainly have to follow up for those who've asked that question. And also recognize, I think, a lot of your slides, you said, we don't know, we haven't done a lot of research on this. And we have a question here. Why aren't there more research studies related to this?
So I think for a couple of reasons. One is I think we're much better at, in people who have pediatric conditions, we're much better at taking care of them when they're children in these centers. And so we tend to address everything when they're children. And then once they become adults, people kind of disperse. So people are not in one place. But even when we think about, the study here at NIH, they've been doing this McCune-albright natural history study for so long, but gynecology only got involved recently. And so it's a little bit of specialties not talking to each other, which is starting to change. And then the fact that something's rare. So when something's rare, so if I think about something like blood clots, the risk of blood clots in the general population is 1 in 10,000 women. If you give birth control pills, it becomes like 4 to 5 in 10,000 women. If you're pregnant, it's like 9 in 10,000 women. Well, to see whether McCune-albright is associated with more blood clots, you would need at least 10,000 women to see what the change is. And there just aren't 10,000 women with this condition to study. So a lot of it has to do with the patients being dispersed or the specialties not talking to each other, but also for some things to really know whether this is a problem or not, you need large numbers.
Yeah. And is it something we can hope? I mean, that makes complete sense. And is it something that we might be able to hope for in the future now that there is more?
Yes, we're working with Dr. Boyce to add a lot of these questions around women's health issues and birth control. It's interesting. I think groups like your group can make a huge difference. So the MAS Alliance, so other rare diseases, the research has been done through the support groups and through the advocacy groups, because they have led the fight to really learn more about these things. And so research has been done through questionnaires, through the support groups and things like that for us to learn more. And I would be happy to partner with you guys if you wanted, if your participants are really interested in, we could kind of come up with some questionnaires and see if people are interested in filling them out, or so that we can learn a little bit more.
Yeah, I think that would be great. I mean, you could definitely count me in for participating in something like that, as it's, I think that people really forget about, or sometimes forget about, the hormonal side of the disease, because they're so concentrated on the fibrous dysplasia part of it, because that's the pain. But I think that the endocrine side and, everything that we have been talking about today is something that you live with every single day. And it's so important. And it's a lot of times how the disease becomes present.
Absolutely.
Most of the time.
Women's health issues understudied in general, right? Women's health issues are understudied in the general population, but they're also really understudied in people who have other illnesses. And so we find that that's why pediatric gynecologists a lot of times take care of adults with unusual conditions, because nobody's even paid attention to this aspect of people's lives, and yet it's such an important aspect, and that's just very common.
Absolutely. Yeah, it's definitely something we'll have to explore as a community. I'm getting some questions in here from the chat as well. One person is asking about, and if there was any increased pain associated with hormonal birth control and FD. In the group, I realized that the group you asked was a small group, but
we did not ask that question, and I have not heard anything around that. And I think that's a question that we should be asking in the future.
Absolutely. Absolutely. Yeah. There's just so many unknowns, which is, I think, again,
I
why
mean,
it's so
one thing that
important.
I would say as a patient, and I know it has not been studied yet, but a lot of times if my menstrual is really heavy, I will get a fibrous dysplasia cyst. It will become more prevalent at that time. And I have seen that a lot. Or a lot of times I will get a cystic pimple and I'll have a cyst on my ovaries and I'll have a fibrous dysplasia cyst all at the same time. So it's this like triple effect.
So that's a really good point that, you know, and we see this in other situations. Like I have patients with chronic pain or other things, and you know, pain from menstruation is normal because you release these chemicals that cause these uterine contractions that cause pain. And pain upon pain is a stressful event, and stress can trigger things. And so I wouldn't be surprised that that can happen around menstruation. Things get worse.
Yeah.
So now I have a couple questions here that they're not really questions, they're just sort of mentioning things that maybe you can talk to. Fibroids. Is that?
Fibroids?
Yes.
Yeah, I don't know. You know, I have zero information about the rate of fibroids in women with McCune-albright. We did not ask the question. In the general population, it's 1 in 4 women has fibroids, and in women of African descent, it's 1 in 3 women. So you can imagine something that's that common in the general population is going to happen in women with McCune-albright at some point. It might have nothing to do with the MAS. It's just going to happen based on general population.
And I realize we are coming up on time here, so I appreciate it. If we can just get a couple more of these in. Forced menopause, is that a thing with that?
So it's interesting. I think what people mean by forced menopause is when we give GnRH agonists. So let's say somebody has endometriosis. That's where the lining of the uterus grows outside. That's very painful. If we can stop the hormones, we can make the endometriosis get smaller. And that is what we treat with GnRH agonists. The GnRH agonists cause the brain to stop making the hormones that makes the ovary work. And again, that doesn't work so well with McCune-albright. As a matter of fact, the children with precocious puberty, which we normally treat precocious puberty with these agents, we cannot use these agents in McCune-albright because the problem is not that the brain is making the ovaries work, it's that the ovaries are working on their own. So that would be one way to do forced menopause. I don't think that would work really well. So it wouldn't prevent these cysts from coming on here and there. Although it might get rid of the period and it might make estrogen be low at other times of the month when you don't have cysts. The other way to force menopause is to take both ovaries out. So that causes a menopause. And again, we don't usually recommend that. And the reason we don't, you know, when we have early menopause, it has a huge effect on osteoporosis and bone density. And has a huge effect on heart disease. So we know women have much less heart attacks than men until they go through menopause. And then after menopause, they catch up with men. And that's one of the things that estrogen replacement, if you give it early in low doses and through the skin, seems to really help prevent both of those problems, both osteoporosis and heart attacks.
Interesting. Yeah. I'll just take one more of these, maybe 2 more here. It's uterine artery embolization.
That was a great question. I actually didn't address that. So uterine artery embolization, they throw little beads on the uterine artery, so it blocks the uterine artery. And it doesn't make the whole uterus die because the uterus gets blood from a lot of different places. But if you have fibroids, it makes the fibroids get smaller because they die. They don't get as much blood flow. It's good for people with fibroids. It's not good for people who don't have fibroids, who have a pretty small uterus or pretty small fibroids. So it works well when there's a lot of fibroids. It doesn't work well if the uterus is sort of a normal size or only slightly enlarged.
And then this last one, it seems important to me, the hysterectomy. You mentioned that really it should be, avoided if at all possible. Anything else, are there reasons with MAS that we need that to happen? Or?
No, so I think hysterectomy is a great surgery for somebody where nothing else works. It's just that once you take somebody's uterus out, they can't have children. And so we don't want to do that in young people if we don't have to. And it is a surgery, it's a major surgery, so it's associated with complications. But if somebody's having a lot of bleeding or a lot of problems and nothing else is working, it absolutely will solve the problem. And I perform hysterectomies all the time, and it's a great tool, but because it's completely irreversible, it's not what you want to go to in a young person or first line.
Thank you. I think at this point we are going to wrap up and try to get answers to questions that we weren't able to afterwards. Please do reach out to us. I'll put up our information so that folks can see it. And before I close out, Lauren, is there anything else you wanted to add?
No, just thank you so much. I think that this was such an informative conversation, and I know is on the minds of all of the MAS patients. So I really and truly appreciate it, as I know it's on my mind. And I think that a lot of really good questions were answered today. If somebody, do you have any advice for anyone in our community, Dr. Gomez-Lobo, of how they get in touch with a pediatric gynecologist, especially for the caregivers, or is there anywhere where they could look for information?
Yeah, so there's a society that I'm a past president of, so I have to give that disclosure, called the North American Society for Pediatric and Adolescent Gynecology. It has some nice patient handouts and information, and there's a list in there. I'm not sure if you have to be a member, but you could always reach out or have a doctor reach out if you want to refer. There's listing of people who are members of that society who around the country and the world.
Great.
Excellent. Yeah.
NASPAG.org.
Can you say that again? Because I'll put it in the chat.
NASPAG, North American Society for Pediatric and Adolescent Gynecology, so NASPAG.org. NASPAG.
I'll drop this in the chat. I'm also going to drop the treatment guidelines, the more general, not just for endocrine or reproductive health guidelines for FD and MAS. And I think with that, I'm going to close us out for now. Thank you so much, Dr. Gomez-Lobo, for your insight. And
thank you for having me. It brought up a lot of ideas, so thank you.
Great. Yeah, I think for us as well. Thank you to Lauren for sharing so candidly and for your leadership that you've shown to this community. We are deeply grateful for you. Thanks also to our donors who made this possible, including Ionis and Ultragenics and our Charlie's Angels Giving Circle. I'll post again that organization, our treatment guidelines, and the webinar survey in the chat. Your response really helps us so much to measure the impact of our programs and plan for the future. We really appreciate your thoughts. At this point, also, this is our last webinar, but we are looking for volunteers, those interested in helping with FD/MAS Global Awareness Week, which is coming up in February. And then those interested in the honor of becoming a board member. There's a survey under Get Involved for interested board members on our website, and a place for you to show your interest in Global Awareness Week in our post-webinar survey. So look for those links in the chat And thank you so much, everyone. Be well and happy holidays.
Bye. Happy holidays all. Thank you.